Good morning to all. First of all, I thank Dr. Devi Meenal and KARE team for giving me this opportunity. We will start with the simpler cases first. Okay, then we'll proceed. So here, what's the finding and what's your diagnosis? So once you get the diagnosis, you can move on to the next questions. Okay, what are the findings in radiograph and barium studies, radiological management, and poor prognostic signs and what's the transient phenomena. So by this time all of you would have observed, so here this is a bowel within bowel appearance and this is a intersusception. And what are the different layers? The outer layer is going to be the intersusception, which is very important. You have, since it's going to have a prognostic value on deciding about your treatment. The outer hypoechoic layer, the inner layer is produced by the mesentery and the collapsed intersusceptum. So what are the other signs that can be appreciated in ultrasound? In longitudinal sections you can appreciate a hair fork sign. So this multiple concentric rings are produced by the multiple layers of bowel. And other important things you have to notice in this section is whether there is a trapped fluid. Here you are not making out any fluid in between these rings. So you have to look for any trapped fluid, and otherwise also in the peritoneal cavity any abnormal fluid, especially if it's a large fluid with the particulate material is there. So you will be suspecting perforation. Then that's going to be a contraindication for your guided procedures. Okay. So conventionally radiograph, going to the radiograph may be normal or certain findings like a gaseous abdomen, and if you see a small bowel obstruction signs, once again a contraindication for a pneumatic or a ultrasound guided reduction procedures. And the similar signs may be seen in less than 10% of cases. That's target sign and meniscus sign. And the barium, the classical sign described as the coiled spring appearance. That is when the intersusception is not very tight. The contrast can seep in between the in the lumen of intersusceptum and also in between the layers. So that will produce a coiled spring sign. So regarding the management, of course, what we commonly use the ultrasound guided hydrostatic reduction. So where simple, even you can be asked about the rule of 3. So 3 attempts with the 3 minutes interval and a height of 3 feet. That is 100 centimeter. So rule of 3 can also be asked. Then so decrease success rate for all this procedure. So it can be these are the cases which you should not choose. Okay, when the symptom is more than 48 hours or signs of bowel obstruction, perforation, when the peripheral rim thickness is more than 1 centimeter and a large internally trapped fluid, when you can appreciate a lymph node which is more than 1 centimeter, then these are certain contraindications for a hydrostatic reduction techniques. Then transient phenomenon. So this you would have observed in CT, especially in adults. So you would have appreciated a intersusception in a plain study, in a contrast study you may not be. So the criteria for that is it's not at all associated with any lead point or a bowel obstruction, and as such the intersusception measures less than 3.5 centimeter, and so the causes can be idiopathic, Crohn's, or it can be seen in celiac and Crohn's disease. So next I will be showing 4 sets of barium images. So even you can be asked about the swallow techniques. Okay, so I placed these 4 cases. So the first 2 cases, so the common finding is the esophageal dilatation. But the first one we know it is the bad beak appearance or a smooth tapering, symmetrical tapering, a short segment tapering. That is diagnostic for a primary achalasia. Okay, the tapered segment is so smooth and usually it measures less than 3.5 centimeter. Okay, it's such a short segment and the dilatation is usually more than 4 centimeter. Then plain radiograph findings in the case of achalasia will be a the mediastinal widening, okay, with the convex borders and mottled. This is a supine I have taken from a CT image. So mottled lucencies due to food and air, and usually the dilated esophagus will be up to the level of azygos arch. It will be tethered at the level of azygos arch. And the most important finding in all this will be a absent fundal shadow. So that also points towards the achalasia and the phenomenon associated. So the questions can be, phenomenon associated will be a Hurst phenomenon. So when the intraluminal pressure exceeds that of the lower esophageal tone, the intermittently contrast empties into the stomach. Then regarding the various barium swallow techniques, so simply telling the three techniques: single contrast, double contrast and the mucosal relief. Single contrast, you use a low density barium and a small 100 ml, and it's mainly used for any contour abnormalities and large lesions, large polypi lesions. Double contrast, you give a small quantity high density barium followed by a pneumatic distension, and which is very useful for smaller lesions like erosions and ulcers and early neoplastic lesions, for which a double contrast. For mucosal relief, of course, most of the time we are not at all rather doing. Previously, it's a popular technique for demonstration of varices. So it's after just at the end of the swallow, when the barium, when the esophagus is collapsed, the imaging is done. Okay, so that's for the varices. So then achalasia, how to differentiate a primary and the secondary, and in the even the X-rays itself you can appreciate the features of aspiration pneumonia and other things. Then the second case is the dilated esophagus, but if you look at the lower margin, it is a patulous GE junction. So that is diagnostic of a scleroderma, and in even you can appreciate fine reticular lesions in the lung. So that's diagnostic of a scleroderma. So here the complications are going to be GE reflux, esophagitis and peptic stricture. So at a later stage it can mimic a achalasia, but usually at this stage the strictures usually they are at a higher level in the compared to achalasia and scleroderma. The strictures are at a higher level, and the mucosal irregularity due to ulcers can be appreciated. So next to these two cases, of course, just to mention about a malignant lesion. So here it's a, here also upper esophagus dilated, and here your long segment stricture, and here these are the mucosal irregularities and shouldering. So that's a highly diagnostic of a malignant lesion. And the other one is the same case after a Hellas myotomy. The findings here is the ballooning. So after a myotomy, this even in some cases this part may be even more ballooned out. So that is now the contrast is freely entering, but till there is a hold up of barium. So next we are moving on to the next case. So here findings, what's the diagnosis and what is this finding, what is the criteria for that, and what's the diagnostic criteria for the primary. So now you would have observed there are multiple lesions you are appreciating with the wall thickening is so bulky and the enhancement is less than the normal mucosa, and this phenomenon it's called aneurysmal dilatation. So it's diagnostic of a GI lymphoma. So can you mention in any other condition where this aneurysmal dilatation can happen apart from lymphoma? So the pathogenesis here is just a infiltration into the plexus, autonomic plexus is lost, so that's why. So similar changes can rarely happen in other conditions like just metastasis, and rarely anaplastic adenocarcinomas can also produce a similar picture. So the diagnostic criteria for a primary, the question is primary GI lymphoma. So for the diagnostic criteria is going to be here in predominant involvement of bowel only with the regional nodes. no generalized lymphadenopathy, mediastinum is normal, peripheral smear is normal, liver spleen is normal. So since why we are concentrating about this primary GI lymphoma and Dawson criteria, since the prognosis is going to be good in an isolated primary GI lymphoma. And the risk factors are the chronic H. pylori gastritis, HIV, celiac disease and inflammatory bowel diseases and other immunosuppressant therapy. These are the cell types. It's better to know about all. So NHL is common and also we know B cell tumor is common. To know knowing about the cell type is very important since this mantle cell lymphoma can present as a multiple polyposis. Though we say lymphomas, they common in stomach, ileum, but in a follicular lymphoma, it's more common in a duodenum and jejunum. So we must know about basic pathology. So CT findings, so already we have discussed in the same case itself. So a bulky wall involvement and here the differentiation between a adeno and this is here the enhancement is delayed and it's less than that of the muscle. Okay, or you may be equal with that of the muscle. And of course, aneurysmal dilatation will be seen in about 30% of cases and all those things. Other forms of lymphoma and CT staging is very simpler, but nowadays TNM staging is also followed. A tumor confined to bowel is 1, 2 limited to nodes, 3 widespread nodes and 4 is a disseminated disease. So moving on to the next case. So findings in A is we are seeing a intraluminal mass in the ileum and a speculated enhancing mass in the mesentery, and here is a edema in the loop and a hypervascular metastasis. So the diagnosis is carcinoid. Okay, diagnosis is carcinoid. So here once again common sites and the markers are also important and clinical features. Since the carcinoid syndrome rarely occurs in a bowel carcinoid, since the serotonin is metabolized by the liver. So the symptoms are different from the lung carcinoid in a bowel carcinoid, and the imaging features. The imaging features are categorized under bowel as such. It can be the primary mass can be a small intraluminal well-defined mass. The secondary other features will be a multiple mesenteric nodular masses will be there. They will be enhancing and they will have a speculated margins due to fibrosis and the desmoplastic reactions. Multiple nodes will be there and the metastasis. And the other important aspect is the as such the feature of mesenteric ischemia may be there, either due to direct invasion by the mass by direct invasion of the vessels or due to secondary narrowing as such due to serotonin can cause a sclerosis, elastosclerosis of the vessels. So ischemic changes also can be a part of your carcinoid spectrum. And role of radionuclide study in a carcinoid is very important. Sometimes the patient will be presenting only with the metastasis. So for localizing the primary and staging and receptor status, especially for octreotide, it's very important for planning the radiotherapy for this patient, since most of the patients will be present very late. So these are the that's a gallium 68 octreotide PET CT or a SPECT can fusion that can increase the sensitivity, and there's a scoring is there for assessing the severity. Krenning score assesses the severity of the lesion, and also it's also useful for follow-up cases also. If negative in these two, then you can proceed with the iodine 123 MIBG scintigraphy. Then angio appearance, of course, it's a classic sunburst or a spoke wheel appearance, associated mesenteric ischemia and venous occlusion I have already discussed. So next, moving on to the next case. So here the findings, a brief pathogenesis, and so here it is a malrotation, that is the duodenum, even the third part duodenum itself didn't cross the midline. The entire bowel loops are, small bowel loops are on the right side. So rather it's a non-rotation. So what is this sign? So it's a whirlpool sign seen in associated complication, that's a midgut valvulus is the complication of the malrotation. So this so what it happens is around SMA there will be a clockwise rotation of SMV and the mesentery happens. So brief pathogenesis is must know that since any deviation from the normal 270-degree counterclockwise rotation is interrupted, this happens. So it can be an incomplete rotation, that is between 0 to 270 degree. Anything is called an incomplete non-rotation. That case I showed you. That is the entire small bowel loops on the right side and the large bowel loops on the left side, and a very rarely a reverse rotation where the colonic loops enter earlier than the small bowel loops. That's the post-arterial segment end. So that's a reverse rotation. So barium, idea of barium study is to detect the DJ fluxure. So that's the role of barium study. So DJ fluxure, so in this case it's very easier since it's a complete non-rotation. Otherwise usually the normal location of DJ fluxure will be at the level of L1 vertebra to the left of left pedicle. Okay, so on that it will be usually at the level of the duodenal bulb. So the idea of barium study is to identify that any deviation from that, whether inferiorly placed duodenal bulb or that of the inferiorly placed DJ fluxure or towards the right side is diagnostic of a malrotation. If it's associated with the valvulus, then the classical sign, Karp-Cross sign will be seen. In ultrasound, of course, we will be always looking for the SMA-SME relationship, either towards the SMA towards right and SMA on the left, but it will be absent in many cases. So either or SMA can be anterior also. So now it's the more towards the D3 segment, that's the third part of duodenum. So normally between SMA and aorta, the duodenum will be crossing. Now too, even with the graded compression technique, even in ultrasound, the same thing can be, it's well seen in CT. So the retromesenteric D3 segment identification. So if it's identified, that's rules out a malrotation. So this is what I was telling about. So normally normally at this level you expect a duodenum. Okay, that part of duodenum. So that's the diagnostic sign of malrotation. So associated, these are some of the associated conditions that can be asked as a question in a case of malrotation. So next. So here this is by this time you would have, so this is a large exophytic mass from the lateral wall of the right lateral wall of the rectum, and the signal intensity, it's a heterogeneity centrally, it's a hyperintense, and in T1 also hyperintensity is there. So here this areas of hemorrhage. So common sites and relevant pathology you must know since the management oriented. Okay, the tyrosine kinase inhibitors are used as drug. So next we are move. So that was just okay. So in the conventional study, the margins, just I thought of insisting about the barium studies. So where there will be a large filling defect, well secondary filling defect, where the margin with the lumen will be obtuse or at right angle, since these tumors are intramural with a large exophytic component. So these are the common sites and associations. So especially if you are given it as a long case, definitely all these things they will be asking you. So NF1, familial gist and Cornish triad will be the associated. So CT findings, usually a large mass, the central so heterogeneous enhancement due to central necrosis or cystic changes are due to hemorrhage. Appreciation of it is very important. So since that differentiates it's between a benign and a malignant lesion. So malignant lesions are suspected more than when the lesion is more than 5 centimeter, or a heterogeneous enhancement, cystic and necrotic components. Even malignancy is common in gastric location. Okay, plus of course locally invading lesions under metastasis we always consider a malignant lesion. Then the assessment of response. So most of the time we will be seeing the cases following imatinib treatment. So various criteria are there, resistant CHOI criteria. This one is easier to follow. When the tumor attenuation decreases by more than, so these are the criteria to tell this is a response to treatment. Okay, so more than 50% attenuation decreases, or the tumor size decreases by 10%, or the newer lesion, the liver may be showing newer lesions in a CT, previously isodense, now they may appear in ultrasound, they may appear cystic, so which we should not interpret as a metastasis. Okay, that's a response, a good response to the treatment. So moving on to the next case. So what is the sign you are seeing here? So this is a T1 and this is a fat halo you are seeing, and there is a gross increase in the presacral fat, and if you observe the lower part, you are seeing the fat halo, while it going to sigmoid, the finding is entirely different. Okay, so in the CT it's a gross increase in the mesenteric fat, so mesenteric creeping mesenteric fat, and this MR contrast showing a enhancement of the sigmoid with the adjacent mass. And if you observe in CT, you can appreciate smaller sinus tracts. Okay, so this is Crohn's. Crohn's can involve isolated large bowel involvement can occur in about 30% of cases. Without small bowel, only large bowel can be involved in Crohn's disease. So this is a Crohn's disease. The stages, varying stages of Crohn's. So this will be a penetrating stage where the ulcers, sinuses, mesenteric abscess. So this is an inflammatory mass. This patient also had a fistula to bladder. So various bowel signs are described. Okay, so that will describe its stage in the active or quiescent or fibrostenotic. And another peculiarity of the Crohn's is both stages, active inflammation and the fibrostenotic stage, can coexist. So that's the peculiarity of Crohn's. And when you mean penetrating diseases, we mean sinus tract, fistula and all those things. And mesenteric, then the other important aspect of here, the technical aspect is the how current days for evaluation of early changes in Crohn's, the technique is so we are using MR enterography, and I have placed briefly about the techniques and other things, various. So even the severity index, so the important part is that the bowel wall thickness, enhancement and T2 hyperintensity is taken into consideration, and various index is given, and thereby the severity is assessed. And the other important aspect is the small bowel obstruction can happen with even a edema or a fibrostenotic form, which can also be easily differentiated with T2, where the fibrostenotic form may show a T2 hyperintensity in the wall. Even it may look like a thickened bowel, but it will show a hypointensity. So then common question, other questions asked in a Crohn's or ulcerative colitis will be the extra-intestinal findings. So there will be sacroiliitis. So even in a given case itself, that image may be showing a feature of sacroiliitis. Okay, always look for a sacroiliitis. The other findings, of course, primary sclerosing cholangitis, venous thrombosis, polylithiasis, nephrolithiasis, avascular necrosis, and other things. These are differentiating points between ulcerative and Crohn's. The important aspect is usually ulcerative colitis, it's a contiguous involvement, and it's and the symmetrical involvement of the wall. And while the Crohn's, it's usually skip lesions are common, and that of the asymmetry wall, the most of the time the mesenteric wall is involved, and never this abscess, fistula, sinus tract never occurs in a case of ulcerative colitis. So whenever all these things have happened, so always it's diagnostic of Crohn's disease. So this one, so what's the diagnosis? So CT features and complications. So here you are seeing a cystic lesion. Okay, this is cecum, and adjacent to that you are seeing a cystic lesion. So this is the appendix and the terminal. So this is a mucocele of appendix. So here the findings will be a cystic lesion with a mural calcification. The causes, since you must, in all cases, you must know a little bit pathology, since it can happen in benign condition and also may be associated with a tumor also. So either it can be a simple mucous retention cyst or a mucinous cystadenomas or carcinomas. So which we can, with the CT, if you have a thickened wall more than 5 mm or a mural nodularity, enhancing nodular mass, if you are appreciating within the mucosal, then you have to suspect a malignant, either you have to suspect a neoplastic lesion. Then other important part while imaging a mucosal is the associated pseudomyxoma peritoneae. So either a pericecal or in the entire peritoneal spaces or adjacent organ you will be seeing a deposits, and the other complicated, it can be even a lead point in intersusception. So this one, yeah, so here the so thin walled bowel, so in the plain study minimally dilated, but the bowel wall is very thin, and the enhancement, so this is a normally enhancing bowel, and here it's a poorly enhancing, and in the SMA it's a occluded. Okay, distal SMA including the right colic and the ileocolic trunk is occluded, and this is a case of the SMA thrombo. So it's probably a embolism since it's so distal. So questions can be classifications and specific findings, irreversibility markers, and radiological management. So this is the causes. So either it can be acute or chronic. Acute is the arterial occlusive, either embolic or thrombotic, veno-occlusive, and non-occlusive, so mesenteric ischemia and in strangulations. So findings, these are non-specific findings, okay, bowel wall thickening or whatever it is, but specific finding is the identification of the thrombus and the absence of wall enhancement and a papery thin wall. It's a highly diagnostic. That also says it's a very irreversible damage has, how we are telling for an infarct. Here also irreversible damage has occurred. And other important findings are the pneumatosis. Mesenteric is a non-specific one. So other four are very specific signs for mesenteric ischemia. So pneumatosis, then gas in the portal vein and other things. So associated solid viscera changes will be there. So these are the irreversible signs for ischemia. Irreversible ischemia signs. So thinning, as I mentioned already, thinning and poor enhancement, extra bowel gas, that's the pneumoperitoneum and other things. Absence, bowel wall enhancement, all those things are diagnostic of irreversible ischemia. Management, of course, when the peritoneal signs are there, of course surgery is surgery is indicated. When there is no features of frank necrosis and other things, so immediate procedures for arterial thromboembolisms and other things, aspiration, embolectomy, and catheters, thrombolysis, and so many other procedures like angioplasty with stenting. Even for venous mesenteric ischemia, of course, long-term anticoagulant therapy and other things. So with this is going to be the last slide, and I will finish with this. So due to similarity, I have placed this one on. First one is the lumbar hernia. So the questions may be asked is the boundaries for superior and inferior lumbar hernia. So between the superior lumbar hernia is between the internal oblique and the erector spinae, and then it is an inverted triangle, and this case is a superior, and it can happen in the post-op patients also. And this we routinely we will be seeing this. This is a indirect inguinal hernia, and here where the inferior epigastric vessels are, the hernia arises lateral to the vessel. So how the differentiating point for a direct inguinal hernia will be where it will be median, and the important sign lateral crescent sign. And this is the Spigelian hernia where between the rectus, it's a lateral, it happens lateral to the rectus, and this is the site exactly. Okay, so where the Spigelian hernia occurs, and this one is a left paraduodenal hernia. So it usually behind the fourth part of, and here the encysted and the clumped bowel loops, and usually it's between the stomach and the pancreas, or even it can be seen posterior to pancreas. So so whenever a case like this is given, so these are comes under group of internal hernias. So other internal hernias, right paraduodenal hernia, and boundaries and through which foramen it's and the vessels. Here the diagnostic criteria will be the inferior mesenteric vein and the left coeliac artery will be in anteromedial relationship. So these are other internal hernias. So I thank you for your patient listening, and I once again thank KARE team for giving me this opportunity. A very